Okay, well, John, I should really get rid of my imposter syndrome with that introduction. Thank you so much. Let's see if I can get these up. I'm going to assume that this is working unless someone tells me otherwise. So thank you. Okay, perfect, thanks. So thank you so much, and congratulations to the Pain Society of Alberta for hosting this awesome conference, 4,000 registrants. It's just amazing. Maria Hudspeth and I are honored to co-chair the Canadian Pain Task Force, which we hope is bringing hope to over 7 million Canadians living with pain. Among us today are clinicians, researchers, educators, decision makers, and most importantly, people with living or lived experience suffering the stigma and disability of this invisible disease. Many of us have personal reasons for being here. Let's always keep people with lived experience in our minds and at the center of what we do and partnering with what we do. By full disclosure, the slide deck contains a lot of content. I will not speak to everything. However, I have purposefully left it there for your subsequent perusal, should you so wish. The Canadian Pain Task Force was established in March last year to help the Government of Canada better understand and address the needs of Canadians who live with chronic pain. Through to December 2021, the task force is mandated to provide advice and information to guide government decision makers towards an improved approach to the prevention and management of chronic pain in this country. We are currently halfway through our 3-year mandate, and today I will very briefly touch on the Phase 1 report findings. I will focus on Phase 2, summarizing the process and importantly, key learnings from the consultations held across Canada. And while I submit that the status quo is not okay, there are pockets of amazing activities across Canada ripe for scaling up and unprecedented provincial activities already underway. And finally, I will share my optimism for Phase 3 very briefly, for which we are just beginning to shape plans. Off the record, I'm hoping we are laying the foundation for a national pain strategy, which I include in small font, as this is not an officially endorsed component of our mandate. The task force is comprised of 8 members, including people personally impacted by chronic pain, Indigenous peoples, researchers, educators, and health professionals from medicine, pharmacy, mental health, and rehab specialties who are typically involved in the treatment of pain. We are supported by a 16-member external advisory panel, which provides up-to-date scientific evidence, expertise, experience, and perspectives. Here's an overview of our timeline. We began in March last year, and since which we have submitted our first report in June 2019. We've engaged in cross-Canada consultation since then, and this week have just submitted our second report and chomping at the bit to get going with our Phase 3 mandate. Our first report submitted last year to Health Canada contains a wealth of material. It is easily found on the Health Canada website. It informed the themes for our consultations during Phase 2, which include gaps in access to timely and appropriate care, chronic pain surveillance and health system quality monitoring, public awareness and education training for health professionals, and research and related infrastructure. However, we know there to be pockets of excellence in all these areas, which need leadership and resources to amplify and spread. Phase 2 of our mandate involved using the Phase 1 themes to guide national consultations to identify best practices and elements of an improved approach to the prevention and management of chronic pain in Canada. As part of our engagement process, the task force undertook an extensive series of consultations between July last year and August this year. This kicked off with the inaugural regional workshop here in Lake Louise at last year's conference, and you in the West have continued to be engaged. I can tell you that 36% of online respondents were from Western provinces, for which we thank you. We also completed rapid evidence reviews on preventing the transition from acute to chronic pain, and also one on managing pain, mental illness, and problematic substance use. We also did an analysis on the economic costing of direct and indirect costs of chronic pain during 2019, and scans on population-based disparities and disadvantage, and also on COVID-19. Recognizing the unique historical and cultural context for Indigenous peoples, we engaged Indigenous people a little differently to explore their views. We collaborated with elders and knowledge keepers and representatives from the Native Women's Association of Canada, the Assembly of First Nations, Thunderbird Partnership Foundation, and Indigenous Services Canada to ensure that input was gathered in a way that was compassionate, socially and culturally informed, and inclusive. A reflection from one of the task force members, Hani El-Gablawi, was that this was one of the most moving professional events he recalls ever attending. And certainly what we learned from Indigenous people very significantly helped inform the task force's phase 2 report. Last week, the task force submitted our second report to Health Canada, which is currently entitled Working Together to Better Understand, Prevent, and Manage Chronic Pain. It's a what we heard style report. The report will be officially launched in November. That would be in a few weeks. It reflects the ideas raised during our engagement activities through 5 interconnected themes. Firstly, we heard from participants that access is impeded by shortages of healthcare professionals, long wait lists, and financial barriers, particularly for people on low incomes or those without private insurance. Some of the most successful practices for addressing these challenges are patient-oriented models which provide flexibility to meet an individual's needs and goals, including stepped care and hub-and-spoke service delivery models, rapid access clinics, mobile and evening clinics, virtual care and telemedicine solutions, and self-management resources. You've already heard about some of these. Our second theme was around the need to address public awareness, education, specialized training for pain. For people, as people living with pain, clinicians and communities need to be empowered, knowledgeable, and supported to manage chronic pain. This starts with an understanding of chronic pain as a disease in its own right. We need to improve public awareness and reduce stigma, and improve the quality and quantity of education for health professionals. Thirdly, we heard there is a need to improve our understanding of chronic pain by strengthening and funding pain research. This includes expanding pain research in Canada by establishing an integrated and common understanding of pain and minimum data collection standards, building more collaborative pain research programs, and supporting basic discovery and innovation, as well as real-world patient-oriented research. For our fourth theme, monitoring population health and health system quality, participants told us we need to develop standards for data collection, expand surveys and administrative data, and better coordinate actions across jurisdictions. I think this is really important, reducing variability across the provinces and territories. Hopefully we'll have time to discuss this later. And finally, we learned about the negative experiences facing many Indigenous peoples living with chronic pain when navigating a health system often containing bias and racism, and privileging conventional approaches to health and wellness. Future approaches must recognize traditional Indigenous knowledge, medicine, and healing, and apply trauma and violence-informed approaches. This report reflects not only ideas and perspectives raised during our engagement activities, but also explored new themes related to societal inequity and COVID-19. As with many chronic diseases, pain is not distributed equally among Canadians. Biological, psychological, social, cultural, and other factors influence the occurrence and severity of pain, and barriers to care are higher in populations affected by social inequities and discrimination. Trauma and violence-informed care is an essential best practice identified during consultations because it promotes compassion and takes into account patients' experiences, preferences, and possible history of trauma. This creates an environment of trustworthiness and safety. COVID-19 occurred in the swing of our second phase. The health system's inability to effectively manage pain has been further exacerbated by this and the attendant public health restrictions. For many people living with pain, COVID-19 has increased stress, mental illness, disability, and use of substance and medications, as well as reduced access to services and procedures. Increased cases of chronic pain might be seen over time as newly triggered acute pain goes unmanaged, existing chronic pain is exacerbated, and newly emerging chronic pain might potentially develop as a result of post-viral COVID-19 infection. However, responses to the pandemic hold great promise for improving pain care and actually align with best practices emerging from the Canadian Pain Task Force national consultations. It seems very fitting that this time last year, we undertook the first of our cross-Canada consultations in Lake Louise and have just this week submitted our Phase 2 report to Health Canada. And so the Phase 3 cycle begins. Moving forward, we have multiple goals focused on continuing to engage stakeholders, enable and facilitate change, and build awareness around options for improving approaches to pain in Canada. Over the coming year, we will continue to engage virtually as best we can, recognizing the challenges presented by COVID-19. We are just now beginning to shape details of this process, and it will change as the needs arise. By engaging different levels of government, organizations, and others working in pain, we will develop our final report due December 2021. This has been such meaningful work. I've had the great fortune of working with wonderful colleagues on the task force and advisory panel. Special thanks go to Maria Husbeth, who is not only fantastic in her role as co-chair, but has also become a good friend. We have been blessed with an incredible secretariat led by Andrew Taylor, not only supporting our work, but also connecting us across federal departments and provincial and territorial jurisdictions as well. The Secretariat has facilitated meetings for the task force with people in government, which is evidence for the interest of multiple federal departments with our work. It has been fascinating for me personally to meet with deputy ministers, leaders of the Public Health Agency of Canada, StatsCan, CIHR institutes, Indigenous services, and beyond. I am very encouraged by government's interest in our work, but we need to translate this work into action for the benefit of 7 million people in Canada living with chronic pain. And this is the thrust of our next phase. Thank you.